Okay, so hi everyone. My name is Elena, and I'm an MD PhD student in the Health Research Methodology program at McMaster. Today, I'm going to be talking about some studies that I've been doing that are for the development of a patient-reported outcome measure to assess cough severity in patients who have chronic cough. And we've called this patient-reported outcome measure the McMaster Cough Severity Questionnaire. So just to give some context as to what chronic cough is, so patients who have chronic cough are defined as having a cough lasting more than 8 weeks. And this is a condition that affects anywhere between 2 to 18% of adults worldwide. Up to 60% of patients who have chronic cough have this persistent coughing despite treatment targeting known conditions. So we say that these patients have refractory chronic cough. And there's another subset of patients who we simply cannot identify why they're coughing, and we classify these patients as having unexplained chronic cough. And currently, there are no licensed treatments for these patients. So because there are no licensed treatments for these patients, investigating new therapies represents a really important unmet need. And current clinical trials have different tools that are available to assess cough. There are both objective and subjective tools available to assess cough. In terms of objective tools, we have tools that measure how frequently one coughs in a 24-hour period. And this includes like the VitaloJAK cough monitor and the Leicester cough monitor. There are also subjective PROs that are commonly administered in trials that assess either cough severity or the cough's impact on quality of life. Tools that assess cough severity include a 10-point visual analog scale, or what we call the cough severity diary. There are also instruments that assess cough-specific quality of life. So some of the limitations with existing instruments that assess cough severity includes that, the cough severity VAS, it currently lacks evidence supporting its measurement properties, and it's also a single item instrument, and so it's limited in capturing multidimensional constructs. And then there's also the cough severity diary, which is commonly used, but this is a proprietary questionnaire with limited access to those not conducting industry-funded trials. And also it includes a domain called disruption, which we feel conceptually is related to cough quality of life as opposed to cough severity. And so our team had decided to develop a new patient-reported outcome measure that solely assesses cough severity in patients who have refractory or unexplained chronic cough. And a secondary objective of the study was to then, once we develop the PRO, establish its validity, reliability, responsiveness, and interpretability. So my presentation today is going to be talking about the studies that I've done so far in the development of this questionnaire. The framework that we followed to develop our instrument follows the methodological framework by Kirshner and Guyot. So phase one of the development of our instrument includes item generation. And the way in which we generated items is through a systematic survey of the literature. We also conducted patient focus groups, and we also consulted clinical experts. So I'm going to briefly touch upon the results of our systematic survey. So the objective was to identify both relevant items and domains to assess cough severity in these patients. We searched a variety of databases, also searched a prior systematic survey on a similar topic, and we also searched a reference list of eligible studies. And the studies that we were primarily interested in included studies addressing item generation of other cough-specific problems. We also looked into qualitative studies addressing the experience of chronic cough, as well as cross-sectional studies and longitudinal cohort studies, all on the experience of chronic cough. And when we did this, we were able to identify 61 eligible studies to include in our qualitative synthesis. From these eligible studies, we had reviewers in duplicate extract statements that could inform candidate items or domains for our instrument. We also had a steering committee comprised of myself, a methodologist, and also a clinical expert to develop a taxonomy to organize all extracted statements. And from those extracted statements, we were able to generate items and domains through iterative discussion. So this is the conceptual framework that we ended up deriving from our results. So we were able to identify sort of two major domains under cough severity, the urge to cough and also cough. And then we also identified sort of subdomains, frequency and intensity of the urge to cough symptom, and control, frequency, fit or bout duration, intensity, and associated features or sequelae of cough. So in total, we identified 43 items for our instrument from this stage. We then wanted to do focus groups with patients with chronic cough to further gather patients' perspectives on this on this topic and whether or not that would inform further candidate items or domains. So we recruited 16 patients with this condition from McMaster University Medical Center, and we ran 3 focus group sessions, and we had a trained person who was trained in qualitative analysis to identify themes independently and duplicates using directed content analysis. In addition to the focus groups, we also had experts, key opinion leaders in chronic cough, sort of weigh in on the items that we generated from the systematic survey and the focus groups. So we first surveyed experts on what questions they felt would be important to assess cough severity, and then we also showed them an item pool with the results of the systematic survey and the focus groups. And then we ran meetings with these experts to discuss their feedback, and we used their feedback to further saturate our conceptual framework. And our final conceptual framework was used to inform the construction of an item reduction questionnaire, which was used in the next phase of our project. So after doing the focus groups and consulting clinical experts, this was the new proposed conceptual framework. So we now had 51 unique items related to cough severity, and we also added an additional subdomain related to cough triggers. So after generating all of our items, we then proceeded to the next phase of our study, which was to reduce the items for our questionnaire. And the approach that we took was to use the clinical impact method, which prioritizes items that patients would endorse as important and items that are generally most commonly occurring among these patients. We then wanted to do a factor analysis among items that are most highly endorsed to explore the validity of, or to explore whether or not, to categorize items under appropriate domains. And then we also wanted to word all of our items in response options. So in terms of the item reduction study, we had a steering committee and patient partners who used the results of our item generation stage to generate a questionnaire. And this questionnaire was one that we used to ascertain both the frequency and the importance of items. We recruited 100 patients for this study. And this is just an illustration of the questionnaire that we administered. So we asked patients to consider their cough severity over the past year, and we listed off a bunch of symptoms that they either may or may not have experienced. We wanted them to indicate whether or not they felt that symptom was problematic, and if they did experience it, to what degree did that symptom bother them. And so we took the product of those two scores and generated a score for each of those items to really identify which items would be most important to patients. And so we recruited patients for the study from McMaster, University of Calgary, and University of Massachusetts. Generally, we included adult patients who had refractory unexplained chronic cough, and we excluded any patients who had significant smoking history, had issues that prevented their optimal participation, or if they couldn't speak English. And then, so that study is actually just complete. We have finished all 100 interviews, and I'm currently analyzing the data. And the next step of this study is for me to do a factor analysis, gaining insight into the validity of intuitive domains and potentially exploring the possibility of other domains in the items. And in this factor analysis, I aim to include items that are endorsed as problematic by more than 30% of patients. Once we end up choosing the optimal domain, we will then want to do some further item reduction, eliminating items that may be redundant. And we can do this by looking at their inter-item correlations. If inter-item correlations are more than 0.65, we may consider just combining them into one item. And our hope is that in the end, we have an instrument that is no more than 12 items with at least 2 items per domain. And we will then construct our response options for our final items with 7-point Likert response options. After I complete this phase, I will then want to do pre-testing of the instrument. And the aim of pre-testing would be to get patients to provide their feedback on the clarity, comprehensiveness, and ease of completing our instrument. So this is a study that we're currently planning. We have submitted to ethics approval, and we are planning to pre-test our instrument on 15 patients with refractory or unexplained chronic cough, and hopefully recruiting patients from the McMaster University Medical Center. Once I finish off with pre-testing, I then want to assess the validity, reliability, and responsiveness and interpretability of our instrument. And our current proposal is to do that in the form of a prospective observational cohort study. So the overall aims of this future study would be to evaluate its cross-sectional construct validity and test-retest reliability. And these are measurement properties that are key to instruments that have a discriminative purpose, so that aim to detect differences between patients at a single point in time. Another aim of our instrument is for it to be able to detect changes in cough severity within patients over time. And so if we want to ascertain the evaluative properties of our instrument, we would want to ensure that it has good longitudinal construct validity and also responsiveness. Another aim of this study would also be to estimate the magnitude of within patient change in the MCSQ total and domain scores that we would consider to be the minimal important difference. So this is an overview of the proposed study that we have to test those measurement properties. Essentially, we would want to do an 8-week prospective observational cohort study of 200 patients with chronic cough, wherein we stratify them into a responder or stable cohort. In the responder group, we define this as patients who we feel their cough will change substantially over time. And these are patients who either have explained chronic cough and would likely respond to to treatments that would target their reason for coughing, as well patients who have refractory or unexplained chronic cough and would likely respond to this new therapy called gefapixant. And we would also have in our study patients who we anticipate to remain stable over time. They would be sort of enrolled in a usual care group. And these are typically patients in clinic who, after many investigations, nothing seems to help with their cough. And so as part of the study, they would just undergo the measurements that we do at week 0, 4, and 8. And the measurements that we will be taking include both objective and subjective measures of cough. So in terms of assessing the measurement properties, we want to assess the construct validity of our instrument by calculating Pearson or Spearmint rank correlations between scores on our instrument and the other instruments that are used to assess cough or other constructs of cough. We would use data on all patients at baseline to inform the cross-sectional construct validity of our instrument. And then we would also use data on all patients from baseline to 8 weeks to inform the longitudinal construct validity of our instrument. We'd also want to assess the reliability of our instrument, particularly test-retest reliability. And so the reason for us to stratify patients into a stable and responder cohort is that patients who remain stable over time, we would want to use their scores over 4 weeks to inform an intra-class correlation coefficient that would tell us the test-retest reliability of the MCSQ. We also want to assess the responsiveness of our instrument, and the way in which we would set out to do this would be to look at patients in the responder cohort, determine whether or not our instrument detects statistically significant within patient change over 8 weeks over time. We'd also want to calculate an effect size statistic or a standardized response mean, and a responsiveness statistic. And all of these would inform how responsive is our instrument to change over time. And the last thing that we would want to ascertain is, what is the interpretability of our instrument? What is the within patient change in score on the MCSQ that represents the minimal important difference? And the way in which we do this is to use an anchor-based approach in which we administer the patient's global rating of change as the transition anchor over 4 weeks. And then we estimate what change on the target instrument, the MCSQ, corresponds to patients who report that they've had a minimally important change over time. So that's a little bit about my project. I want to thank you all for listening, and I also just want to acknowledge all these people who've contributed to the work. Happy to take any questions.